Hello and welcome to the Your Only Doc podcast. I am Dr. Shashank. Today we are diving into tumor lysis syndrome, the cellular apocalypse that strikes when cancer cells die faster than the body can clean them up. Let's get started. Imagine this. You're on rounds and a young patient with newly diagnosed leukemia is undergoing their first round of chemotherapy. Within 24 hours, they develop muscle cramps, nausea, confusion, and their labs are all over the place. High potassium, high phosphate, high uric acid, and their calcium has dropped like a stone. What you are witnessing is not just metabolic chaos, it is tumor lysis syndrome, a potentially fatal oncologic emergency. In a rush, here is your condensed guide to tumor lysis syndrome. Tumor lysis syndrome, or TLS, is a life-threatening complication that occurs when cancer cells, especially those highly sensitive to chemotherapy, break down rapidly, releasing their intracellular contents into the bloodstream. The key biochemical disturbances include hyperkalemia, potassium greater than or equal to 6 millimoles per liter, hypophosphatemia, phosphate greater than or equal to 1.45 millimoles per liter, hyperuricemia, uric acid greater than or equal to 476 micromoles per liter, and hypocalcemia, calcium less than or equal to 1.75 millimoles per liter. The most commonly affected patients are those with hematological malignancies such as acute lymphoblastic leukemia and high-grade non-Hodgkin lymphomas, particularly Burkitt lymphoma. However, TLS can also occur spontaneously or in solid tumors with high proliferative activity. Diagnosis follows the Cairo-Bishop criteria, which defines laboratory TLS as the presence of at least 2 of the aforementioned metabolic abnormalities within 3 days before or 7 days after chemotherapy initiation. Clinical TLS includes these lab findings plus 1 or more clinical complications such as acute kidney injury, cardiac arrhythmias, seizures, or sudden death. Management begins with prophylaxis. All high-risk patients should receive aggressive intravenous hydration, typically 2 to 3 liters per square meter per day, started 12 to 24 hours before cytotoxic therapy. The goal is to maintain a urine output of at least 100 milliliters per meter square per hour. Diuretics like furosemide may be used if volume overload is a concern, but only after adequate hydration is established. Allopurinol at a dose of 300 milligrams per day helps prevent uric acid formation by inhibiting xanthine oxidase. However, it is not effective in reducing already elevated uric acid levels. For high risk or already elevated uric acid levels, Rasburicase is the preferred option. It is given as a single intravenous dose of 0.15 to 0.2 milligrams per kilogram and rapidly converts uric acid into allantoin, which is more soluble. Hyperkalemia is managed with intravenous calcium gluconate for cardiac stabilization, insulin and glucose to shift potassium intracellularly, and potassium binders or dialysis if needed. Phosphate binders like sevelamer can help reduce phosphate levels, while hypocalcemia is treated only if symptomatic to avoid further calcium phosphate precipitation. The cornerstone of TLS care is vigilant monitoring. Electrolytes, uric acid, renal function, and fluid status must be checked every 4 to 6 hours in high-risk patients during the first 72 hours of chemotherapy. Dialysis is considered for refractory electrolyte disturbances, fluid overload, or worsening kidney function. Let's go deeper, the advanced dive into tumor lysis syndrome. Now, shifting gears for the next few minutes, if you're a specialist, hematologist, or a physician managing high-risk oncology patients, here is where we look beyond the basics. One of the growing debates is the use of risk-adapted Rasburicase dosing. While traditional protocols recommend weight-based dosing, recent clinical protocols suggest that a single fixed dose, such as 6 milligrams in adults, may be just as effective for most cases, especially where resources are limited. This approach significantly reduces cost while maintaining clinical efficacy. There is also increasing concern about Rasburicase-induced hemolysis in patients with glucose 6-phosphate dehydrogenase deficiency. This is particularly relevant in certain ethnic groups with higher prevalence. Current best practice recommends screening high-risk individuals prior to administration. In emergencies where screening is not feasible, alternative management with allopurinol, and aggressive hydration should be considered. A challenging area of discussion is the management of spontaneous TLS. While rare, spontaneous TLS is increasingly reported in solid tumors like hepatocellular carcinoma and small cell lung carcinoma. These cases often present late with established renal failure and metabolic abnormalities. Prophylaxis guidelines are still murky for solid tumors, and more clarity is needed on when to preemptively hydrate or initiate urate-lowering therapy. In terms of monitoring protocols, some centers now utilize real-time telemetry-based potassium monitoring in intensive care settings, particularly in unstable patients. The aim is to anticipate cardiac events before overt symptoms occur. A future-looking area is the role of biomarkers for TLS prediction. Serum lactate, dehydrogenase, uric acid trends, and tumor burden scoring may offer a predictive toolset for identifying patients most likely to develop TLS before biochemical derangement occurs. This could lead to more personalized prophylactic strategies. Lastly, in pediatric oncology, there's emerging evidence that uric acid clearance varies based on age and tumor type. Pediatric protocols now emphasize tailored Rasburicase dosing and more aggressive hydration strategies, especially in acute lymphoblastic leukemia and T-cell lymphoblastic lymphoma. 3 essential takeaways from today's episode. Number 1, tumor lysis syndrome is predictable in high-risk cancers, and prevention is more effective than treatment. Do not wait for derangement, act early. Number 2, Rasburicase is a game changer for uric acid control, but be cautious in glucose 6-phosphate dehydrogenase deficient patients. Fixed dose strategies may soon become standard practice. Number 3, constant monitoring every 4 to 6 hours in the critical 72-hour window can be the difference between stability and a fatal event. On our next episode, we will dive into hemophagocytic lymphohistiocytosis, HLH, the cytokine storm you cannot afford to miss. Make sure to like and follow us on LinkedIn, Instagram, Facebook, X, and YouTube to stay updated. And hey, if you enjoyed this, come say hi. You can find me on Instagram. Drop a message, let me know you are listening, and share what you think. I would love to hear from you.